The second part, today we'll talk some about superior ventricular arrhythmia. Atrial, they have different parts. They have different classifications. Usually we have atrial and AV junctional, or we call them nodal premature beat. Paroxysmal superior ventricular tachycardia is very common for patient. We call them PSVT. Usually have three types. Atrial tachycardia, we call AT. Atrial ventricular nodal reentrant tachycardia, we call them AVNRT. Atrial ventricular reentrant tachycardia, we call it AVRT. The most common is AVNRT. Nodal reentrant tachycardia is the most common cases. The atrial flutter and the atrial fibrillation. For elderly person, AF is very common. Atrial premature beat is the most common arrhythmia for everyday patient, for indoor patient, for outdoor patient, for everyone, me, and for me and for you. Maybe also everyone maybe have atrial premature beat. These are phenomena, but not a disease. For some elderly person, they have a lot of atrial premature beat, maybe 20,000 per day, 40,000 per day. They feel very uncomfort. They feel palpitation every moment. It's very common symptoms. But for this kind of patient, maybe they needn't any treatment. They take some drugs, have no effect. Nowadays, some hospitals, they take RFCA, cardiac ablation, to treat this kind of disease. But it's very uncommon. It's uncommon treatment. Atrial premature beat, we can recognize them. The P wave is different from the normal sinus P wave. The PR interval is normal. QRS may be often preceded by the QRS complex. QRS complex is similar to the normal sinus beats. Let's see this one. We can see a P wave is premature, maybe early up here, then followed a QRS complex. For sinus rate, maybe regular. For premature beat means earlier beat. For some special cases, we can see QRS complex followed by the P wave because of the conduction of AV node is not recovered from the before beat. Also, we see some it's different QRS complex followed by the P wave because the P wave is too early. For ventricular muscle, AV nodal function is not recovered. Let's see these two ECG. The first one is by Germany. What's by Germany? It's one normal, one non-normal. Repeat 3 times. We call them bigeminy. The second is trigeminy. Trigeminy means 2 normal, 1 abnormal. They repeat 3 times, or even more. Repeat, and repeat, and repeat. 3 times we call a rhythm. Atrial bigeminy is the first one. Trigeminy is the second one. We also see something about junctional premature beat. It's very, very clear to be identified because the PR interval is shorter than atrial premature beat. Atrial premature beat, PR interval is longer than 1.12 seconds. But for the junctional premature beat, maybe before, maybe in the QRS complex, we can see. Also, the P wave is behind the QRS complex. For PR interval is shorter than 1.12 seconds, and the direction is retrograde because the atrial muscle excitation from the below part of the atrium to the upper part. So the direction is down. This another part. We can see the junctional premature beat. The PR interval is shorter than atrial premature beat. We also see some P wave is following QRS complex. The RP is shorter than 0.20 seconds. The second part is very important. It's very common in clinical cases. Premature beat is common in everyone. PSVT is common in indoor patient. The 3 major types we have seen. What's atrial tachycardia? It's usually is focus. It's from some part of the atrial muscle. This part of muscle maybe generate very rapid heart rate. Is higher than sinus rate. So the rate is controlled by this kind of this part of the atrial muscle. We can see some different P wave, from the sinus rate. The last two is sinus rate. The P wave is up. The only QRS, the PQRS, the only normal. This is the only normal QRS, normal heartbeat. For the others, all the atrial tachycardia rhythm, the P wave is downside. The usually rate of the P wave or QRS wave is usually the P wave rate is usually about 100 to 250. Someone is fast, someone is slow. But for slow AT rhythm, maybe the P wave conduct the atrial activity conduct through the AV node 1 to the ventricular muscle one by one. For the faster atrial tachycardia rate, for the atrial rate is higher than 200. Is usually 2 to 1 conduction. 2 to 1 conduction. For the slow rate of atrial muscle, they usually conduct one by one. Let's see this ECG. You can see the first two is normal, then a premature beat cause a very fast arrhythmia. This one is AVNRT. For AVNRT, we recognize usually the P wave. AVNRT P wave is usually hidden in the QRS complex. We can't see anything. For some leads, we can see P wave just behind the QRS complex. Usually at QRS, usually just below, follow the S wave, just follow the S wave. We can see the P wave in lead 2. The direction is downside because its enrichment route is for in the atrium is from downside to the upside, so the direction is down. For atrioventricular enrichment tachycardia (AVRT), we have two cases, two conditions. Usually, see some patients with WPW syndrome. They have bypass tract. What means bypass tract? Because for the patient, the impulse goes through the atrium part, through the AV node to the ventricular part. This track is the only track. For the patient, they have muscular connections between the atrium to the ventricular muscle. So we call them bypass. For usually bypass track is ventricular muscle, so the bypass conduction rate is very high. Because this kind of ECG call them WPW syndrome. For WPW syndrome, bypass track is two direction. The electric impulse can go through the track from atrium to ventricle. Also can go from ventricle to the atrium. For some ventricular premature beat can go through the bypass track back to the atrium, can cause atrium arrhythmia. Another condition is a concealed bypass. For this muscular connection, usually have one direction conduction. This bypass can only conduct from ventricle muscle to the atrium muscle. In their normal rate ECG, we can't see anything. Let's see. some ECG. The first one is WPW syndrome. What means WPW? W is the first character of three very famous doctor. Three names, just the first letter. We call them WPW because these three very famous doctor has priced their findings nearly at the same year. So just we call this phenomenon WPW. Let's see. This is a very typical delta wave. Between the P wave and the QRS complex, we can see a wave. The PR interval is shorter. And it's caused by the bypass tract. Because the bypass tract conduction rate is very high, they will exciting a small area of ventricular muscle. So this part of ventricular muscle electrical activity will show in the ECG. We call them delta wave. The other part of the ventricular muscle is excited by the nodal conduction, AV nodal conduction. Usually, WPW syndrome have two types. Type A means the VQRS is upright. Type B means usually the V1 QRS is downside. For type A, usually the bypass tract as a left ventricle. It's a bypass between the left atrium and the ventricle, left ventricle. For the B part, usually the bypass as a right part of the heart. PSVT treatment, usually we have two part. For the patient just to catch PSVT, they go to emergency room. The heart rate is very high. Then they take the ECG. The ECG shows them the PSVT. We will do something. For the patient himself, they can increase vagal tone. Usually use Valsalva maneuver. Just impress deeply and catch a breath, then suddenly like this. This Valsalva maneuver, and carotid sinus message means just press at this part of the carotid artery. Usually, we just talk to the patient if they catch the episode of the very rapid heart rate. You just for the finger to press the tongue, they get nausea, or then the PSVT may be stopped. At the emergency room, we usually take to use intravenous drugs. For foreign languages, for foreign countries, you usually use adenosine. For Chinese hospitals, we usually use verapamil. Verapamil is very, very efficient and is very safe. Adenosine for Chinese hospital, we have none drugs. We haven't these drugs. For USA, Canada, or European countries, use adenosine. If the patient catch the PSVT, this associated with the patient feel chest pain or pulmonary edema, is acute heart failure or severe hypotension. In emergency room, the patient maybe do electrical cardioversion immediately. Usually we call them shock. If the patient have low hypertension, angina, or pulmonary edema, acute pulmonary edema, you just remember shock immediately. For the patient have the PSVT, they have ECG, they have no episode. Usually the doctor maybe provides the patient to do cardio ablation. This is cardio ablation catheter. The last two is real cases. Atrial flutter and atrial fibrillation is very common in elderly persons. Usually the person is higher than 60 years old. These two diseases is very common. Usually women is higher than men. The patient with these two kind of disease maybe have no reasons. For atrial flutter, it's not common than atrial fibrillation. Fibrillation is common than atrial flutter. The atrial rate is very fast in these two kind of arrhythmia. Atrial flutter maybe we can calculate. Usually the atrial flutter rate is between 250 to 350 cycles per minute. For atrial fibrillation, the rate maybe we can't calculate. For some patient, the wave is very low. Flutter waves may be short-tooth, very similar. Fibrillation wave may be irregular. This is atrial flutter. This is atrial flutter. We can see short-tooth lag. The mechanism is reentrant mechanism. The impulse go around the tricuspid valvular. The lower part atrium of right atrium to go up through the atrial septum and go down as a lateral wall, like this. Ventricular response to the atrial impulse may be 1 by 1 or 2 to 1, 3 to 1, 4 to 1. This one is 4 to 1. 4 atrial impulse conduct 1 QRS. This one is also flutter. We can see this 4, this 3, this 3 flutter conduct 1 QRS. Let's see what's atrial fibrillation. It's just you remember irregular fibrillation wave, irregular heart rate, ventricle rate. This one is very typical. For the A, we can see the fibrillation wave. For the B, we can see the fibrillation wave. For the C, we can't see anything. We can just see some very small waves of fibrillation wave. Treatment of the atrial flutter and fibrillation. We just take some anti-arrhythmia drugs. We usually take type 1, A type, C type to slow the heart rate. Maybe use type 4, CCB, or beta blocker type B. For type 3, we use the patient with chronic heart failure or coronary heart disease. We usually to take amiodarone. For some patients with chronic heart failure or with hypertension or with pre-excitation syndrome, WPW, the patient with atrial flutter or atrial fibrillation, we usually with cardioversion immediately. It's most effective. For all kinds of these patients, we can do the RFCA, cardiac ablation, to treat them forever. This is atrial fibrillation ablation. We do some circle ablation or do some line ablation to treat them. This year, European Society of Cardiology Congress expressed a new guideline for atrial fibrillation control. We can see the CC to ABC. C is confirmed atrial fibrillation with ECG or Holter ECG. Then to 4S control. Then to the ABC treatment, anticoagulant, and to control the risk, to treat, to control the heart rate, or control the rhythm. Thank you.